Thank you, Julie. Welcome to all of you joining us today for Harnessing the Power of the EMR to Improve Workflow, featuring Central Hastings Family Health Team. This webinar is the next in a series of webinars brought to you by the Pan-Canadian Change Management Network. I'm going to get a few housekeeping items out of the way, starting with this notice that the webinar is actually being recorded and will be posted on Infoway's website. All participants' lines are muted throughout, so you will need to use the question and answer feature if you wish to ask a question. And the questions can be asked throughout, and I'll get to that in a moment. But first, a disclaimer, and I'll give you a few moments to read this. My name is Cindy Hollister, and I'm a member of the Pan-Canadian Change Management Network and a Director of Professional Practice with the Clinical Adoption Team at Canada Health Infoway. I'm hosting today's webinar, and I'm very proud to be introducing you to Dr. Adam Stewart and Julie Page from Central Hastings Family Health Team in Madoc, Ontario. Central Hastings Family Health Team was recognized in 2014 by Canada Health Infoway in partnership with Accreditation Canada as a leading practice organization, and also by the Association of Family Health Teams of Ontario with the Bright Light Award. Dr. Adam Stewart received his Bachelor of Science honors in Physiology from the University of Western Ontario, where he also completed his medical degree and family medicine residency. Adam joined the Central Hastings Family Health Team in July of 2009, and he was the lead physician for the health team from 2010 to 2012. Adam's professional interests include working with EMRs, where he has developed an expertise and technologies to improve workflow and enhance patient care. He practices as an ER physician and rural physician with the Central Hastings Family Health Team. Julie Page, RN, graduated magna cum laude from Ottawa University with a Bachelor of Science, Nursing Perinatal Concentration. She went on to receive a Master of Science from Queen's University and a Master of Health Studies from Athabasca University. Julie also is an internationally certified project management professional. Currently, Julie works at Central Hastings Family Health Team as the Program Coordinator, System Navigator, focusing on the chronic disease management programs and broad system navigation. Her focus is on quality improvement using the EMR to support change. So these are our objectives for the webinar today, to define workflow analysis and integration within the context of the National Change Management Framework's 6 core elements, and also to hear the story of how one family health team has leveraged their EMR to improve and optimize workflow. So we're going to do that using this outline, a little bit about Canada Health Infoway and the Pan-Canadian Change Management Network and the National Change Management Framework, just as a bit of an introduction. But really the bulk of today's webinar is going to be our feature presentation and hopefully leaving lots of time for questions and answers, and then a little bit of review of available resources. So as I mentioned, I would get back to you with how to ask a question, and this is done using the question and answer panel at the top of your WebEx screen by clicking on the drop-down arrow and selecting the Q&A and sending your question to all panelists. So the question and answer period will actually begin, as I've said, after all of the presentation is finished. But please keep the questions, as you think of them, send them in. And, potentially if we don't get all the questions answered before we finish at 3 p.m., we'll be able to get some of them answered after the webinar for you. So Canada Health Infoway, its mission is fostering and accelerating the development and adoption of electronic health information systems with compatible standards and communications technologies on a pan-Canadian basis with tangible benefits to Canadians. Infoway will build on existing initiatives and pursue collaborative relationships in pursuit of its mission. The Pan-Canadian Change Management Network is supported by Canada Health Infoway's Clinical Adoption Team, and it's a grassroots collaborative of change leader enthusiasts from across the country, sharing best practices and ideas since 2009 in November. So the network actually facilitates a national community of practice for change management leaders who are involved themselves in the implementation of electronic health solutions, and provides an environment for discussion, networking, and knowledge sharing. It was founded to share experiences and identify common goals that address ongoing change management-related issues and concerns within the e-health space across the provinces and territories. As of 2014, there is also an Infoway Change Management Reference Group made up of change management leaders from across the country. This reference group meets quarterly to provide national expertise, insights, and input to shape change management strategies and outputs focused on accelerating adoption and benefits realization of digital health. The National Change Management Framework is depicted here, and it was developed by the Pan-Canadian Change Management Network as an integrated framework for describing change management activities within the context of e-health projects. It consists of these 6 core change management elements that you see here, and there's actually a lot more detailed information for each of these elements that can easily be found within our online Pan-Canadian Change Management Network community, and you get to that via Infoway's corporate website. But I've also included links at the end of this presentation. I'm not going to go into all of the details on each of these because in the resources you'll see that there's some links to 2 of the previous webinars in this series that actually does go through each of the 6 core elements in more detail. So because this webinar has a focus on workflow, I have included this definition as found in the National Change Management Framework for Workflow Analysis and Integration, and that definition is a process of understanding current work processes and opportunities for improvement, and allowing new processes using e-health solutions to be sustainably embedded into the culture. And now, without any further ado, I'm going to turn the presentation over to Adam and Julie from Central Hastings Family Health Team so they can tell us their story about how they've harnessed the power of their EMR to improve their workflow.
Good afternoon. Thank you to Infoway for giving us this opportunity to share our story with you. I'm Julie, and you'll hear from Adam quite shortly. Adam has a lot that he wants to share with you, and so he has many, many slides, which you'll find he's going to go through fairly quickly. Here's our outline of what we want to do with you today, who we are, how we set up our technology-wise, our current digital workflow, etc. And we'll share with you some of our challenges and successes. So Central Hastings Family Health Team is located in Southeast Ontario along the Highway 7 corridor, about halfway between Ottawa and Toronto. We have 2 main clinics, one in Madoc and one in Marmor, and those are 18 kilometers apart. And then we have a satellite clinic in Gilmore, which is 36 kilometers north of Madoc, and that's a NP-led half-day. We have approximately, and do I have that? I don't know. We have approximately 7,500 rostered patients. We are a rural practice. Our catchment area is 1,460 square kilometers. It's huge. Our demographics show that our population has a lower education level, which does affect literacy. We have an older population, high healthcare needs, a low socioeconomic status, and very few of our patients have private coverage. A little bit about our team. We are a relatively small family health team. As noted, we are multi-site with the 7,500 rostered patients. This includes a nursing home and a retirement home. We also have a number of non-rostered historical patients. We see the occasional cottager, you know, the fish hook through the finger. And we also offer a walking clinic to the high school students during the school year. Our patients receive comprehensive primary care, and we have a number of value-added chronic disease management programs, including in our staff numbers here, we have physicians, 6 physicians, which actually we're coming down to 5, and we are recruiting a physician, and all of their staff, which is 10+. There's an administrator and you can see the Family Health Team staff here. Total about 32 people when you add up all the part-timers who are on our team. And I think at this point it looks like I'm handing over to Adam. Go.
Hello there. So right now I'll just give you a brief overview of the way our servers and EMR is set up. We use EMR, TELUS, or previously Practice Solutions, aka PS Suite EMR, which I believe many people are familiar with, but I realize there's other EMRs out there as well. Right now we have, as Julie pointed out, there's the Madoc town and the Marmora town that are about 10-15 minutes apart. We used to have everything on one server, and the people from Marmora would have to connect into the Madoc server, but due to the rural area that we're in and the poor internet speeds, that really wasn't feasible. It had about 30-second delays with every single click. We eventually had to split servers so that the Madoc physicians keep their charts on their server, and we keep our charts on our server, and we VPN into each other's clinics when needed. So do the allied health team members as well. And as Julie mentioned, north of us we have a satellite site that one of our nurse practitioners tends to every Tuesday afternoon, and they VPN as well into the Madoc server for the charts as needed. And that works very well. Like many of you, I'm sure, who on EMRs we've had our labs for some time downloading directly into our charts. And more recently, we've been set up with the Hospital Report Manager, which has been great. Any dictated note from the local hospitals, and even some from Toronto, and that there's more and more hospitals signing up. But any dictated note, instead of being faxed to us now, is just uploaded in a typed note. From there, at each site there are fax servers. So anything that's faxed to us is not printed on paper, but rather turned automatically into a PDF form. Other outside lab results, X-ray reports, things like that, and they're all then inputted into the charts. So what I'd like to do in the next little bit is give you a little bit of an overview on how of the workflow of a typical patient visit. We'll take some side steps here and there, and maybe look at the workflow of an actual program as well. But some of this information it spans from being very basic for those of you who may be just starting out on an EMR, but it also gets up to some pretty advanced stuff too. So I think there's some stuff for everyone in this presentation. So at the start of a visit, a patient comes in and they register. They swipe their health card, and we'll start from there. So at all of our computer screens, whether it be the physicians, the staff, anyone who's working here has the daily appointment schedule open on their screen. And when a patient comes in for a visit and they swipe their health card, immediately an up arrow shows beside their name. And we use these arrows to show each other where the patient is in the course of their visit. I'll show you over here. So you can see when the arrow is pointing to the right, it means the patient is being prepped in the room. When the arrow is down, that means the patient's ready for me as the physician or the nurse practitioner, whoever, to go see. And then it shows left when the visit's finished. And that's just a basic feature that helps really the workflow and the flow of patients through the clinic. It helps people know when a room's free, when the patient's done, when they're ready to be seen. When the patient first registers, there's a few things that the staff are trained to do that might be done preemptively, such as NIPASings for well-child visits or pain inventories for pain visits. They're trained, and they'll get the patients to fill those out preemptively so that they're all ready to go once the clinician goes in the room. One exciting role I see in the future, I'm not affiliated with Cognizant MD in any way, but for those of you on TELUS Suite, you might want to check out that website. They have tablets that patients can fill out these pre-visit custom forms on tablets, and then they're automatically uploaded to the EMR without having to scan or even go through paper that way. So that's exciting, and I think we're going to hopefully move there in the future. As well, throughout the day or visit, we use the rapid instant messages with the EMR technology. For example, if one of the visit ushers wasn't sure if I needed a urine pregnancy for a patient, they could quickly ask that in the form of an instant message. So at our clinic, we have what we call ushers, or They're basically medical staff or office staff who are trained to take blood pressures, put patients in rooms, prep them, and so forth. But we're using that term Usher from time to time. So at every visit, we started some time ago. Every patient gets a blood pressure check, so we're good on that. But they're also trained that in the appropriate settings to take the temperature, weight, height, vision, things like that. When the usher is prepping the patient, they have these pre-made stamps. So stamps is what we call them, and I think a number of people call them as well. Other EMRs or users might call them templates. Basically, they're kind of pre-made notes with tab-through options to fill in the blanks, or tab-through default options, or things like that. You can see in these little snippets of screenshots, after every colon, there's a place to enter a data piece, and the little dot, even as a spot that the tabbing through will stop, that someone can enter that in. So afterwards, the usher can quickly enter in the visit prep for some of these types of visits. Here's a special example of a prep visit, and we'll talk about the diabetes encounter a number of times throughout the presentation. But the usher preps the chart with a stamp that looks something like this. And obviously there's a blood pressure, height, weight, and waist circumference. But also there's even written instructions there to remind them to check the reminder system that's right in front of them to say, is the patient due for an eye exam? And if so, they just double check when the last eye exam was, because often, if you're like our clinic, we never receive optometrist notes or rarely do. So it's up to us to ask the patient that, as well as the patient is due for their annual foot exam, that they'd be prepped for that, so it makes the visit go a little faster when I come in. So the patient's prepped, and now it's time for the clinician, like myself or a nurse practitioner, to come in to see the patient. And there's always a role for free text. Not everything fits into a classic pattern or box that will fit nicely into a stamp or template. So I've just shown a little example of a free text note, a SIP-SOAP note that was just free text. That there's no stamp or anything that was used there. But many things do fall into patterns, and anything that's recurrent, your EMR can save you time, both in terms of documentation and reminding you to do things. Plan can already be pre-typed in a lot of fashions. So here is an example of a common cold stamp that we use. Again, for those of you not familiar with TELUS or PS Suite, the little dots are little tab-through spots, and then the little things that are what are called chevrons, the little double arrows on either side. Those are default answers that can either be tabbed through with a single stroke, or typed over, or deleted in some cases if it's not relevant. Afterwards, after I'm done a few typing through, tabbing through, and filling the blanks, final upper respiratory tract note might look something like this. There's other options too. Here's one for a stamp for diarrhea. Again, already asking the quick pertinent positive negatives about antibiotics, recent travel, spoiled foods, etc. There's another one for knee pain. Quick fill in the blanks or type overs. Sometimes stamps aren't just used for the SOAP notes. They can be used to document anything that you say repetitively. For example, I have one that if you're always saying the same advice to a patient after a visit, talking about sedating medications, for example, you always say the same thing, so instead of typing it out at the end of every note, have a quick stamp that you can, with a couple keystrokes, to put in. Here's one, for example, on discussing the rest of prednisone. Another one on starting SSRIs. Again, always the same advice, but it takes 2 seconds at the end of the visit, or less than that actually, to quickly document the use discussed. The final example is something I use in letters to patients. And so if I'm in a diabetes visit, for example, I can generate I wanted to give them the take-home advice on their insulin, for example. And if you're rhyming off a bunch of numbers and what to do, obviously the patient might not take all that in or remember it all, so I like to actually write it out. So instead of handwriting it out, I have a stamp ready to go that with like 2 keystrokes I can generate a letter to the patient, and then another 2 keystrokes I can input the stamp that's kind of pre-made that says, you know, as you can see, your bad times start increasing your Atlantis, or you can customize the number there. So and you can quickly delete the parts of the letter that aren't relevant to that patient. But you can see how just within 5 seconds you can give them a take-home summary of a typed advice that won't be misunderstood. So at the end of the visit, or the patient comes for a diabetes visit or a sore knee, I always like to use opportunistic reminders. So in our EMR system, and I think many other EMRs, there's an opportunity to make your own reminders. And some people are a fan of them, and some people just like minimal ones. I personally like a lot of them. I'll make reminders for updating a person's kidney function blood work every 6 months if they're on an ACE or an ARB, or their TSH at least once a year if they're on thyroid med, or more quickly if the last one was abnormal. Obviously, most people have reminders for their PAPs and mammograms and stool tests. So at the end of every visit, or if there's time, even a minute or two, I like to maybe take and head off 1 or 2 of the reminders when I can. So I'll just draw your attention, and we'll take a little side step to a programming perspective. There's a reminder there that we built called COPD L1 screen required. What that stands for is a level 1 screen for a COPD program. So what we did there is that as part of our lung health program in the early stages, we started screening people to see who is at risk for COPD. First is what's called a level 1 screen, and that's just a series of 5 quick questions. If all of them are normal, then the screen is negative and the person does not have COPD. However, if the screen is positive, it doesn't mean they do have COPD, but they maybe could, so they should be screened with the level 2 screen, which is spirometry. So we built a reminder to say that anyone who did not already have a diagnosis of COPD, was 40 years of age and a current or past smoker, and as well who hadn't had any sort of lung tests in the last 3 years or screening, should be screened. And this little quick questionnaire we trained all of our staff, not just the clinicians, but even the ushers and the front staff, that if they saw that reminder in the chart, for whatever reason they were in the chart with the patient, they could quickly do that screen and then stamp into the chart, was the screen positive or negative. So from you'll see a little screenshot there of one that says negative, one that says positive. Once that's stamped into the chart, you can then easily pull out searches with your EMR to show who is a positive test and who needs to go to the L2 stage the next time. We will touch upon some of the results of that a little bit later. So once a person is recalled for spirometry, here's another example of a stamp. One of the staff would be putting in these results in this stamp form. So you can see that there's, again, a lot of pre-filled, fill-in-the-blank areas for the FEV1s and FVCs and things like that, as well as a number of default answers where you would maybe tab through 1 or 2 of them and delete the ones that didn't apply. And we'll talk about this a little later too, but by structuring the data input in that way, it's easy to pull out searches that will show, for example, you could pull out patients with an FEV1 less than a certain number, or you want patients who have a diagnosis of COPD on the screen. So you can start pulling data out that way, you can start pulling data out when the data is entered in a very structured format like that. Now, back to the diabetes visit, I'm going to, as part of the encounter, this was, as Cindy talked about earlier, it's kind of a highlight of our team. It's got some national recognition. So part of that is the way we use the EMR to help our diabetes encounter. So for those of you who are familiar with TELUS Suite or PS Suite, there's a feature called an encounter assistant. Now, what an encounter assistant does is there's a little screenshot of part of one off to the left there. It kind of has what's called a custom form format, which some of you may be familiar with, where it's got some pre-populated data, it's got some drop-down menus, some fill-in-the-blanks, a lot of checkboxes. It's very simple and fast to enter the data and go through that in the visit. It's also got some neat little buttons and links that I'll show you in a second. But when you can customize this and build it to your liking, and this one is a fully customized one that I built. So this is a zoomed out screenshot of the entire encounter system. There's a section for glucose and blood pressure, and I'm not sure how well it's showing up on your screens, but basically when you're done doing all the check boxes and you click finish, it stamps a nicely typed note into your chart. So on one side, it was easy to enter quick drop-down boxes and check boxes, and the output is a tidy note that makes sense. So I'll just take a minute and dive into the actual encounter assistant a little bit more in detail. So here's a screenshot of the glucose section. So when I first open it, you'll see that some of the data is automatically populated. It's automatically bringing in the last A1C and the date that it was done. I didn't have to go digging for that or looking through the lab tables or anything like that. There's a section there called the patient's A1C target. So what this is a new thing that we've started to do over, say, the last year or so. Per the new Canadian diabetes guidelines, we no longer try to report who has an A1C less than 7, but rather who is to target, who is to their individualized target. So every patient at their visits will have a target of either 6.5, 7 is the most common, or even 8.5 as per the CDA guidelines. And that's kind of unique thing is that we can start pulling data that way. So with the click of a button, again, this is a behind-the-scenes feature of the encounter system, but you can build it with almost like these hyperlink buttons to do things like pull up graphs. So you don't have to search through your lab table. You can just, one click, you click on that button there, and it would open a graph of the patient's A1C for you ready to see. Or there's a button there that's made to open up the website, automatically opens up your web browser to the CDA guidelines for that interactive tool. You can determine their individualized target for the guidelines if you. So the next screenshot here, I've gone down, I've done the pull down menus, I've filled in a few of the check boxes. I just want to show you that there's other hyperlink buttons. That there's a few handouts that I like to use talking about highs and lows for diabetes, when to drive and driving safety, but I like to have those readily available. So instead of having to even search through my EMR for those handouts, with a click of a button, it can just bring up the handout ready to print off at the visit as you need to. So this type of thing follows through for each of the different sections. There's glucose, there's blood pressure, lipids, whether or not they're on aspirin, their kidney function, eye exam, foot exam, and it goes through all of that. Not enough time to really go through in today's presentation, but I can go more into that someday if you're interested. One thing I'd like to highlight is at the end of the visit, patients are given what's called a diabetes report card. So for those of you who know, remember the days of diabetes passports where patients used to maybe carry around their little passports, and at the end of the visit, you could write in their values for them. But I found that to be really a lot of work. It was redundant. I'd go through all those numbers, and then I'd have to write it after with them. With something like this, it's a custom form that within a couple of keystrokes automatically generates the patient's data, inputs it into this, and our practice solutions came with a default one that looked like this. I took it and customized it. We decided on what parameters we thought the patients would find important, put a little layperson terms beside them so they know what they mean, and then that gives the patient's engagement and a take-home message at the end, so they don't have to remember all the numbers that were just spinning through their head through the visit. Now, we'll just highlight this section at the bottom. It talks about the patient self-management goals. So at the end of every visit, the patient is supposed to be to give a self-directed goal, meaning that it's not our goal. It's what does the patient want to work on for the next 3 months. That's using motivational interviewing and those types of things. Here's a zoom in of that section, and what we'll see is the neat thing about the way the EMR, we've got the EMR working for us here, is that it automatically brings in the goal from last visit into this visit's note and into this form. We didn't have to go back searching through the notes. So, for example, let's say this is a screenshot of the report card from 3 months ago. The patient was in, and at that visit they chose the goal to ultimately work towards losing 50 pounds. So we typed that in 3 months ago. Now this visit, when I'm populating the new custom form, automatically bringing in that box into this box on the bottom left for the goals from last visit. And then we can quickly see, what was their goal, did they meet it, or did they not? And then we type in patient's goal from this visit. And the cycle continues. So, and at the end of the encounter, there are a few highlights of our use of technology are that we use e-fax prescriptions, except for controlled substances like opioids. We have the handouts that are kind of highlighted so that it can be easily printed out for patient take-home information. Most of our referrals and tests are done electronically and electronically faxed, and I'll show you that in a second as well. So, at the end of the visit, now we've got to do some referrals or tests. We have a family health team, so we have allied health professionals here that play a variety of roles. So if we want to refer to one of our programs, we do that all on the same EMR within the patient's chart as well. So we have mental health counseling, dietitian, really important in our diabetes program, foot care nurse. We have nurse practitioners who have certain expertise in diabetes and insulin and hypertension and COPD, smoking cessation. So what we do when we want to refer to one of those programs that we have going, here's an example of another custom form that we've made. It auto-populates some of the information. We click off a few boxes, what they're being referred to, or what they're being referred for, and then just a little side note for future reference, if we ever want all that data is trackable, we can look at later on. We can look at why people are being referred for different reasons. What's a popular one, for example? What's a not popular one? And then quickly, I'll send a quick message to. We have a person designated as AHP as the user initials. You'll see in the top left corner there. And that's our allied health professional referrals inbox or mailbox. So a quick message, mental health referral as a subject, then done. So when the patients are being seen by the interdisciplinary health professionals, we're using the same chart. They're documenting their notes within the same chart, so we're all on the same page. If there's any thing that needs to be reviewed more urgently, then we can send each other messages within the charts, and that's all documented as well. Some of the programs have a discharge custom form that we can then track when and how long they were being seen, what were they discharged for, how was their success, and things like that. Again, all trackable data later on. Any of the referrals to outside the clinics, such as like referrals to specialists, we are set up with eFax, so nothing is printed. We're just press fax and attach a few attachments that are relevant, and off it goes. Requisitions for tests like X-rays or sleep tests or things like that are all done electronically in EMR and also electronically faxed. And then there's someone who's in charge of tracking all these referrals and using the pending feature on the EMR that helps track overdue or perhaps they missed things so they don't fall through the cracks. Here's just a quick example of a requisition from our local Belleville hospital. Here ordering an X-ray. Up in the top section you can see there's even an electronic signature box. So only the user's signature will come up by double-clicking in that box. So it is truly a electronic signature, and then that's automatically faxed rather than printing out. Little note here that because we're rural, we hire our own phlebotomist, so most of our blood work is drawn on site. So that again, we don't even really print off lab recs at the end of it because they're just in the chart, and our blood work person will be able to just put in the chart when the person comes in for their blood work. Here's a little highlight that a lot of people seem to like. You can, on the custom form for a lab rec, you can actually make little buttons. In the top right there, you can see some of the ones that I've made. So they're not visible when you actually print out the requisition, but by pressing one of those buttons, they'll check off automatically pre-X'd boxes. So I have one for standards for diabetes, non-fasting blood work that will automatically do the glucose, the A1C, all that with one click. Actually working on the 2014 rec with some revised things as well. So at the end of the encounter, that's the way we'll follow up. So there's a few different ways we can do that electronically. For important things, I'm very type A, so I don't like to let things fall through the cracks. So one way is that I can send a post-dated message to the front staff. So you can see this message is sent to the MADOC front staff, follow-up mammo results, and I'm post-dating that for April the 1st because the imaging isn't booked until late March, so I can post-date that and then they can follow up later on. Or if there's something that I'm worried might fall through the cracks, I also send a post-dated message to myself. Let's say the patient has been advised to return for a concerning X-ray. but you don't want to leave that to chance that they'll just return. So I'll send myself a little reminder and post-date it for maybe a month just to make sure that they follow through. Now, in terms of the diabetes follow-up, you'll remember this Usher stamp, the prep stamp for the diabetes visit. There's that weird-looking string of letters at the very top of the note that says, if your patient had DM visit today. That's a unique identifier we made a long time ago. It was something that we used to track diabetic visits. The diabetic visit was actually done because you can't really track by billing codes, for example, because the nurse practitioners don't bill OHIP, so there wouldn't be a billing code for a diabetic visit. So this was our way of saying, whenever this identifier was stamped into the chart, it's just part of the stamp, we knew that a diabetic visit was done. That's important for creating recall lists. So I'll get, for example, one person is, here's a sample of a recall list where it's searching for rostered patients who are diabetic, who haven't had that identifier, that patient had DM visit, typed into their chart in the last 110 days, which is just about 3.5 months. We'll get into, in a second here with Julie, why that 250 is important when you look at the second line problem list getting 250, because that's the way we code every single diabetic in our EMR. Staff member can pull this, and if anyone's fallen off the rails, we'll catch them and have them, hey, call them up and get them back in. So I'm going to hand it back to Julie for a second.
Okay. So how did we get where we are now? Well, and really how we got there is really and truly, it has really been one small step at a time. We've taken baby steps to build in our program to get where we are. Here are some examples of how we did that. We started with that registry. We did some cleanup. So we have things like diabetic registries or COPD registries. The standardization becomes very important. So in our early days there, we had to sort of find all those patients who were diabetic and had not been marked as diabetic in the problem list or not diagnosed and really were diabetic. And we decided to go with the ICD-9 code up to 50 for all our diabetics. And even now, we continue to run those searches to clean up the data about every 2-3 months, just to find those patients that may be false negatives. They don't show up on the list, but they should be on the 250 list. And also, we do end up with some lists where polycystic are on metformin. They show up on our list, and we kind of have a handle on which those patients are. Gestational diabetics sometimes show up on the list, and they shouldn't be on. But we found that standardizing the entry and agreeing on a common, we agreed with the 250 for diabetic. We haven't gone to the ICD coding for COPD at this time, but we have done a search and gone through, and anybody that is definitely a COPD patient has been labeled as COPD in the problem list so that we can track them. And these processes go on and repeat. Here's an example of the problem list showing the DM250. We know that our doctors, got to complain about doctors here. Doctors put in things however they want. So somebody might put in DM2, somebody might put in DIB, somebody, you think of it, DM space 2, you think of it, our physicians are creative about how they can input what the problem is. So the 250 really standardizes and gets rid of that problem. For any of our variables or statistics, they can be tracked. We still do run into problems where people aren't putting stuff in standardized, so there is some time going back through. But by starting small, choosing little things that are easy, we found that it's really worked. And we get engagement and agreement by all our practitioners. The EMR can make it seamless. Remember the L1 COPD stamp or the spirometry result stamp or the DM final EA stamp? No? Well, there they were. Adam's changed some of these slides on me. So we do have these regular monthly meetings to agree on these things. We report the data back to them. We analyze our data. We set goals. And we do have subcommittees. And we do find that the PDSA cycle really, really works well. And between the PDSA and the EMR, it has really been key to our success. So how did we get there? Well, we did start with paper charts. There was the EMR in the early years, and this is where we run into problematic. Who could vision where we're going to be today, back when we started with the EMR? So there was no standardization of input. It was used, it was great, but we had no clue as to what we were going to do or how we were going to get it, and that we were actually going to become expert users. It was, again, one small step at a time, and there were some keys to success. Back in 2011, we had an external consult teaching us some best practices in EMR use, and that was probably one of the first big pushes to get us going. We do attend, a number of us attend the annual users conference, and last year we actually had 19 people from our clinic attend the EMR user conference. We have a couple of people in office who are classified as super users. Within our programs, there are program champions for each thing. So those focus groups, there's a specific physician may be assigned to a specific NP who become the clinical champions and help move my QI initiatives forward. We have partnered in the past with third parties for some data analysis, especially when we didn't have the resources to do it. And we never settle on what's here. We just keep moving forward. It's ongoing improvement. But there still is a data burden in the office. Yes, we have faxes coming in. Yes, things go straight into the EMR, but there's still a lot of paperwork still arriving in the office and still has to be talked in. I've already mentioned the dirty data input from the early years, and even now, consistently having to remind people there's so much to remember. The physicians and NPs really want to just do primary care, but reminding them that you have to follow our guidelines. It has to go in as clean data, and then we can come back with the numbers. We do sometimes have some fluctuating engagement levels. Everybody's on board. 6 months later, there's a new flavor of the month, and we have to sort of remind them. Our biggest problem we've run into is we've done all these initiatives, and we have reached some results and some plateaus. Here's an example of our quality improvement monitoring for our DM program. We set goals based on some old Ontario quality improvement initiatives from a number of years ago, and we've maintained those target data, and monthly we monitor how we are doing and how we are performing. Process measures, we're doing awesome with process measures. We have some really, really old data back from 2009, so I don't have data for each of the columns there, but you can see when we started with those initiatives around 2011, there was a huge increase in our process measures, and we really, really have been able to maintain overall, within a % here or there, our process measures. We're really proud of things like 94% of our diabetic patients having an A1C in the last 6 months. Our successes, yes, we did have some early improvements. So you can see there from July 2011 up to July 2012, we made improvements in our patient outcomes, and now we're sort of hitting that plateau. And we've tried a number of different strategies to try to bump that plateau. The lung health program is another one where we've been identifying those patients, as Adam said, with level 1 and patients that require level 2, level 2 spirometry. We've also moving forward with our smoking cessation. 90% of our patients who are eligible have been screened to date for level 1. 32.6 of those level 1 screens have been positive. It doesn't mean they have COPD. We have to go on and we have to screen them for COPD. The spirometry to date, well, when we made these slides, 369 patients have received in-house spirometry, and 24% of those patients have come back with an obstructive diagnosis and another 11% with restrictive diagnosis. So then this gives us another % of patients that we can move on and move into the COPD program for management and education. Adam?
So just a final slide on our successes. We've been able to create basically a well-functioning interdisciplinary team that's largely focused on best practices. We've been able to integrate the EMR fully into the practice, actually, and even drive some of the practice. I think the use of reminders and stamps and custom forms and even the encounter systems as a whole, there's a ton of them that we have and that we use on a regular basis. That's been a huge success. I think the ability to pull all this data and use it to drive our plans for the future and our programs has been, especially in the last few years, we've been using that more and more. It's been very successful. A lot of staff satisfaction. Even myself, I can say personally, like I like my job more because I have this kind of EMR tool to play with in a sense. Patient satisfaction is great as well. They've, like say, for the diabetes report cards that are quickly handed out, that's a great example of something that's a tangible take-home for them. And again, one thing is, don't just get to this big picture of like in a week or in a month. It's all about one little step at a time, picking one little area to improve, and build upon.
We found that the one small step at a time helps with engagement. We try to make these steps fairly low impact. So when we sort of introduced the level 1 screening 3 years ago, it was really, really low impact, but the outcomes in the end and what we look at 3 years later is huge.
So what is next? Well, I think as I talked about at the start, we're carrying on with the reporting of the individualized A1C targets. We haven't got the complete set of data on that yet, but that's an exciting new thing that I don't think many people are doing yet. Our clinic is getting set up more closer and closer to being email friendly. There's still some workflow issues that have to be, and consent issues and things like that have to be sorted out, but we're getting there, and I see that as the way of the future as well, with everyone having smartphones and emails. Working on it, I'm personally working on website patient engagement, where patients can come for pre-visit or post-visit education, and that's good for them, and it saves the clinicians time as well. I already mentioned the Cognizant MD for the visit preps. E-booking is another interesting thing, although for someone like myself who does a lot of same-day access, I'm kind of curious as to how that. I think one of the keys too is we never settle for the status quo. Always, at each of your monthly visits, if you're doing them, always be looking for something to improve. Again, one little small step at a time. And we'll hand it back.
Thank you very much. And as I expected, we have lots of questions that have come in. And one of them was around when you mentioned e-faxing. Was that expertise within the clinic to be able to set up all of the e-faxing, or was that something that you had to go outside to get assistance with?
So the e-fax, when we set it up, there was a person from Paxos Solutions that there was a fee. It was a reasonable fee. I can't remember, might have been like under $1,000 to come in, set up the appliance, set it all up, and get it all set up. And then there was a bit of workflow issues with the front staff that I wasn't really heavily involved with, but the front staff, because the files are then now all of a sudden coming into a file folder, so you have to, instead of checking the fax machine every day, you have to remember the staff have to check the fax folder, and then how they separate those and filter them into the different areas that they go. But that was largely done by basically the people from Paxos Solutions.
Another question is around standardized data entry for preventative care being a bit more challenging than that for chronic disease management. Have you been successful in that so that clinic-wide reminders work well?
I think so, yeah, definitely. That's interesting because I find both the preventative care almost easier because they're so standardized. Now, I don't know if the question is directed, is the person there, because there are some challenges in terms of, say, pap smears that generally there's a 3-year reminder for a standard, right? But some people require a 1-year or even a 6-month follow-up. Or colonoscopies can be 1 year, 3 year, 5 years, or 10 years, for example, follow-up. So there's some workarounds that we have for that work well. But again, for disseminating this through a team-wide, clinic-wide atmosphere, you've really got to start at one step at a time and say, so if you're not having monthly meetings with everyone involved, get them to have monthly meetings. And then at the first meeting, you say, okay, well, guys, let's look at pap smears. How are we going to track those? And have everyone's input, have everyone's buy-in, get a consensus on how that's going to be tracked in the EMR, carry forward for a few months, and then if that's going well, roll out that same type of template for your colon screening and your mammograms and those types of things. I don't know if that answers. I hope that answers the question.
I can just add to that when the front staff get the results in, there's a standardized way that the result is labeled as it is put into the chart. And so we're actually searching literally for some of the labeling and some of the wording. So if, say, an FOB kit is given out and we get an FOB result back, when the front staff input that into the chart, it actually causes the FOB reminder to drop.
Great, thanks very much. Another question is around how do you keep all of the training straight, keep everyone on the same page? Is it a monthly meeting with the whole team or some other method?
So we have, yeah, basically it is that monthly meeting, and again, just trying to maybe, it'd be very difficult to get everyone on the same page for everything all at once. So it's about, yeah, getting your practitioner, we have a practitioner meeting, and we get everyone on the same page for examples that we've just talked about. We have a lot of meetings, but they're useful. Every 2 months now, we also get our own MADOC clinic staff. So that's just not practitioners, that's the reception and administration and front staff as well. Because there might be issues there, like in terms of faxing and scanning and things like that, or patient workflow that are more site-specific. And then we would have an inter-meeting in there. And the same processes, though, picking like 1 or 2 small things, getting everyone on the same page. And you don't get those things. You don't get those things by trying to push them down people's throats. You have to get a consensus and a buy-in, right? So if something's truly not working, people aren't going to do things they don't want to do. So you have to kind of come to a consensus and maybe have a common purpose, agree on a common purpose for some of these things.
We've also, because we actually have these little mini focus groups. So yeah, it's another meeting. We just do it over lunch. And it's usually just a small group of 2 or 3. Usually the physician champion and the NP who's doing some of the program work. And so we have an NP, say, who's an expert in insulin and adjusting insulin. She is not an expert on our COPD. We have a different NP who's expert on COPD. So the one NP isn't going to know all about the stamps and the charting and everything that's going on with COPD, but she's going to be an expert in her own field on insulin. So that sort of helps too. We just have to keep whoever is the expert and the champion up to date.
Actually, and Julie just reminded me of something. Another example that answers your question is sometimes it's useful to have little pilot projects. So if someone has an idea on how to do something with diabetes visits or INR or workflow or something like that, maybe you get the one clinician who wants to do it and 1 or 2 other staff that need to be involved. And you do a little pilot project and work out the kinks, and then once the kinks of that workflow are worked out, you then bring it to the practitioner meeting at the next month and say, okay, this is what's been working. Are you guys interested in doing this? And here's how it works. That's a good way to start small and then roll it out.
Great, thank you. So a little bit related, but maybe more pointed, is what have been your successful strategies in working with the most resistant EMR users that don't want to change the way they chart? So literally the person that is resistant to standardized stamps or template use.
I can speak perfectly to that. So what's interesting is even though we're all using a common diabetes stamp or encounter system, there's a way to do it that not everyone has to use the same stamp. Or
I think we may have just lost the Central Hastings Family Health Team. So I'm actually going to spend a little bit of time maybe doing the sort of finish up of the webinar in the hope that they'll get reconnected. So I will just go on to the next slide that actually provides the resources that that I talked about during the first part of the webinar. And you'll see there that there are the links to the to the recent webinars that I spoke about that will actually give you much more detailed information on the 6 core components of change management. And I think probably listening to today's webinar, you'll have realized that Central Hastings Family Health Team has not only been able to harness the power of their EMR to improve their workflow, but certainly is showing evidence of using all of those 6 core components to focus their work. Let me just go to the next slide. So we have actually amassed quite a few questions, as I expected, and we'll send those to Dr. Stewart and Julie for them to answer. And they've actually provided their contact information here. And on the next slide, I think you'll see mailbox that you can send any questions into the clinical adoption team. So following this webinar, you're going to get an email with a link to the evaluation survey, and hope that you'll fill that out for us. I'll just pause for a moment to see if we've gotten any response from the team yet. No, we don't seem to have. So I apologize for that happening in this webinar today, but as I say, we will make sure that we get the questions sent to them and get the responses and provide those all for you. So thank you so much for joining us today, taking time out of your busy day, and hope that we'll see you for our next webinar.